Everyone at home see the slides okay?
Yeah, they're all good.
Yeah.
All right. Good afternoon, everyone. Thanks to those that are joining from home. Your days off. It should go for about half an hour. But so this afternoon, we're just going to talk about management of massive and submassive PE. So patients that present with big clots in their pulmonary vessels, how do we actually go about resuscitating and managing these individuals? So just the learning points we'll cover. We're going to look at a case study. We'll have a bit of a look over the pathophysiology and some of the physiology of managing big PE cases, how we resuscitate these individuals, and what some of our treatment options can be for these patients. Okay. So overview that we're going to be looking at is that PE ranges from asymptomatic to life-threatening. So we see lots of people with pulmonary embolus and that, but it's the size of the clot and the effect that it's having on those patients' underlying physiology that makes the difference there. And so PE develops from generally DVT that migrates to the pulmonary tree. So DVTs can be in your arms, your legs, and they travel up and they stop within the pulmonary vessels where it starts getting quite small. And that's the impact that it has there. When we look at big PE, and that's what we're talking about today, is big, massive pulmonary embolism. Okay, the pathophysiology that we need to know is that PEs will, if they're big enough, they'll start affecting patients' oxygenation and they cause cardiogenic shock. Okay, so they affect your cardiac output. And so the more extensive the embolus is in size, or you can have patients with multiple PEs, the greater, the more rapid the physiological deterioration that can occur. And we see this on the lung side, where these patients, they get decreasing lung blood supply. And this is where we look at the VQ mismatch. And this is what the VQ scan looks for when they're doing a VQ scan. And this results in arterial hypoxemia. We then see the cardiac effects of managing big PEs and that. And this is where you get increase in your pulmonary artery pressures and you get right ventricular dilatation. Okay, and this causes your right ventricle to decrease in its contractility, cardiac output, and increasing your actual oxygen demand. And all this results in cardiogenic shock. And since we've started studying PEs, it's now we're a bit more appreciative of the right ventricle. When we look at heart failure and shock states and cardiac states, we used to always look at the left ventricular side of things. But the right ventricle, it's a bit of a princess and it doesn't tolerate much insult to it. And it doesn't compensate as well as the actual left ventricle does. So we need to appreciate right ventricular failure. And one of the biggest causes is acute pulmonary embolus. And so this is just a schematic diagram that looks at, so when you're getting decreased left ventricular preload from actual blockage in your pulmonary vessels, which is what transmits your oxygenated blood from your right side of your heart to your left side of the heart, this is where you get this increased venous pressure and tone, and you get this backfill into the right ventricle. And this is when the right ventricle starts to become dilated, poor contractility, and you get impedance and decreased flow through your right ventricle and stuff. And so PE is the biggest causes, but we also see with right ventricular infarct, so inferior STEMIs, cardiac tamponade, pulmonary hypertension, which is a chronic thing as well. So it's all about having a good understanding of the right ventricle in the management of massive and submassive PE. So when we look at worldwide data, there's about 600,000 diagnosed PEs per year. And there's about 2,000 deaths per year. So 1/3 are massive to submassive PEs, so quite big. There's 3 times the risk of having a big PE if you're over the age of 70. And 5 to 10% of in-hospital deaths are actually attributed to PE because we know that in-hospital patients are high risk for developing venous DVTs, basically, thromboembolism. I looked through EDA's data. So from 2020 to 2023, we diagnosed 575 patients with a PE at Sir Charles Gairdner. Fortunately, I didn't have time to actually go through all this and break it down. But there's most probably about 5 to 10 big PEs diagnosed in ED throughout the year. There's more diagnosed actually in hospital because patients are high risk for that and develop it, so up in ICU and stuff. they manage a lot more big PEs from inpatients and stuff. They present that way. When we look at outcomes in pulmonary embolism, so this is some massive pulmonary embolism stuff. So the severity gradient, as we'd expect, goes up. So about 70% of these patients can result in cardiac arrest from their massive PE. And of those cardiac arrests, most will die from it, but there's a proportion that they do go into cardiogenic shock from that. So it's about being aware of those things. So we're going to look at a case now, okay? This is 42-year-old Ben. He's had COVID 11 days ago. He presents short of breath, dizzy, speaking short sentences. He's tachypneic with a respiratory rate of 36. His SATs are 86% on room air. His heart rate's 123 and his BP is 82 on 31. And all that gives him is a shock index of 1.5, which is quite high. So he needs resuscitation and he's got signs of shock there. We're still working out what type of shock it is. Just highlighting COVID is quite prothrombotic, and we are seeing more PEs and potentially more strokes from in the post-COVID era now. So there was some prothrombotic states from having COVID. So this is Ben again. He's a bit plethoric, so we talk a bit about plethoric as you go. So he's quite red and hyperemia from about his nipple line up into his face. His D-dimer comes back at 18.27. His troponin is 147. He's acidotic with a pH of 7.1. His PCO2 is on the upper side of normal at 55, and his PO2 is 20. So he's hypoxic with a lactate of 6.5. So there's some badness going on there that doesn't reassure us. What do you guys think we should do for him?
Recess.
We go to recess? Yeah. Where do you want to go next? Yep, so nice CTPA. Yep. We get, because our doctors are so good here, they like to do an echo first and that, and they have the ultrasound machines at the bedside. So you can see here, this is echo. So if anyone looks a bit at echoes or studied echoes, your right ventricle is normally a lot smaller than your left ventricle. Your left ventricle is your ejection fraction that goes out. His right ventricle's way much bigger, so he's got right ventricular stain. So this is right-sided heart strain that's causing it. He's also got this concept where they talk about clot in transit. So the clot's actually going through into the pulmonary vessels and stuff. The reason they worry about clot in transit is they've got, say, a PFO, so pain foramen alveoli, that is undiagnosed or they don't know about. They can go on and have catastrophic strokes from this as well. The pulmonary vessels aren't going to clean up and hold all that clot that's in there. So when they see that, they see right heart strain, they know that they're dealing with a big PE at the bedside. So we managed to get Ben around to the CT scanner, and this is your pulmonary tree here. And this is the branch of it in the middle here. And this opaque black stuff here, this is all clot in the vessel. Okay, so this is all pulmonary embolus. So this is huge. So this is where your deoxygenated blood is coming back through your lungs, getting oxygenated and going into your right side of your heart. Okay, so this is why they present hypoxic. This is why they're tachycardic. This is why they're hypertensive, because this is all blocked off in their pulmonary artery, and the pulmonary artery pressures are getting greater, and they're actually getting sicker from that, okay, because that clot's blocking it all. And this is what causes this. This is, they spiral and they get sicker, and they'll rest from this. So Ben, we know that he's got a massive PE, he's shocked and he's circling the drain. So we need to look at what we can do at the bedside now to actually manage and resuscitate Ben to actually get this clot sorted out and get his perfusion back and get him out of this cardiogenic shock state that he's in. The clinical presentation for these patients, it's often challenging and non-specific. So PEs, we do talk about historical stuff, whether private DVTs, recent surgery or immobilization, cancer is a prothrombotic state, COVID is a prothrombotic state. Obesity and pregnancy are risk factors, but 30% of the time people have no risk factors and can just get a spontaneous PE. So this is where it converts, because we can start anchoring on thinking, oh, they don't have any of these risk factors. But 30% of the time it can just happen out of nowhere and they can get it. So need to be aware. Certainly if you plaster of Paris and stuff, sending people home and they have sedentary, they don't move around, getting circulation, high risk of DVT and PEs developing. When we look at cardiac arrest data for this, so 3% of patients alive post cardiac arrest have pulmonary embolism from the US registry data. And when these patients present in cardiac arrest, so out of hospital cardiac arrest that's coming out, if we're thinking it's PE, it's more likely if they've got a non-shockable rhythm, high prevalence in actual women, or prior diagnosis of DVT. So if you've seen those things, and they're an out of hospital cardiac arrest, going to your 4Hs and 4Ts. Thrombus is one of those things, one thing that we need to think about in those. At the end of the bed, the things that we want to look for is we're looking for the patient that's shocked with right ventricular failure. So they're going to be short of breath. They're going to be hypertensive. They're going to be tachycardic. They're going to be hypoxic. They present with syncope. We're worried, okay? It's quite a concerning symptom if they've got that, okay? So they're not perfusing. Then they've had an episode where they haven't perfused their brain and it's coming from their heart. So if you've got signs of worrying about PE and they're shocked and they've had a syncopal episode, be worried. Chest pain, it's here nor there. It's common. Some patients can present without chest pain. They can just be severely hypoxic and short of breath, but have a massive PE. Clinical exam at the end of the bed, quite often these patients are sweaty. They're in a sympathomimetic state. They're trying to compensate. They're sweating the diaphoresis. They're not going to be perfusing their tissues because they've got that right ventricular failure. Okay, so they're going to be mottled. They're going to have cool extremities. They're going to be confused and agitation. Another thing that we see in the VPEs is this thing called plethoric. So this is where they get venous congestion above, and it's from the right ventricular failure or from the VQ mismatch. You see them above the nipple line that they're quite ruddy complexion, they're hypoxic, they look shocked. I've seen this with patients with big pericardial tamponades. I've seen it with some patients that are infarcting. We've also seen it in massive PEs. If you're seeing this, be worried and very concerned. They got really bad perfusion going on and they need rapid resuscitation and they're circling the drain. Okay, you can see there it's above the heart that it's all occurring. Okay, it's really worrying. Vital signs, if they start becoming bradycardic, they're most surely going to have a bradyasystolic arrest that's impairing, and it's quite worrying, all right? It's not reassuring, okay? Don't be reassured by it, okay? The shock index tells us that they've got a poor reserve, and it's also an outcome for worse prognosis. Ben at the start, he's hypertensive and tachycardic. His shock index is 1.5. Normal shock index should be less than 0.7, okay? So your shock index is your heart rate divided by your systolic blood pressure. So if you walk into a room and you see a patient that their heart rate is greater than the systolic blood pressure, they've got a shock index over 1. You need to be worried, and we need to do some resuscitation to actually correct that. They become hypertensive, so systolic blood pressure less than 90 or dropping 40 over 15 minutes. Be worried. Hypertension isn't actually necessarily reassuring. These patients are trying to compensate. Okay, they'll still look like shit. All right, but they're just hypertensive and they've still got some physiological reserve that they're trying to compensate, but they'll be sweaty, they'll be diaphoretic, they'll be agitated and confused. And tachypnea, we know with all states of critical illness that a respiratory rate above 30 portrays the worst outcome. Screening tests, we're looking for big PEs. We can sometimes see changes on ECGs where we look for elevation in S1, QT, T3. On there, it's not as sensitive as stuff. D-dimer doesn't tell if someone's got a clot, but if it's positive, then we need to investigate further. Troponin, these patients will get right heart strain with massive PEs, and troponin is a predictor of badness. The higher level, the more infarcting they have got that right ventricle from that. So if we do a troponin on that, it's not a non-STEMI or something that's causing it, it's the big PE that's causing ischemia to the heart and mainly to the right ventricle. Echo can tell us a lot at the bedside, CTPA and VQ scan as well. Radiologically reporting, this is where it can sometimes get a bit confusing and stuff. So the big PEs we're talking about is your saddle or your big lobar. So your saddles is where it's presenting in your pulmonary artery tree. We can see here, this is your pulmonary artery tree that goes through into your lungs, and then this goes through into your right side of your heart with the oxygenated blood and stuff. So this is where, if we saw on Ben CT, this is all clotted off here with the big PE. If you've got smaller PEs, then it goes off into the lobar branches and you can start infarcting these. And then you've got 17 smaller subsegmental branches that come off these lobar branches here. And these smaller ones, if they've got multiple, they can still be sick from it and that. But if they've just got a small one, they're generally okay, and we can just put them on anticoagulation, and they're not going to present physiologically shocked, like if they've got a big saddle embolus sitting here in the pulmonary tree there. You can infarct off these vessels and stuff, and sometimes they will have some hemoptysis from that, and that's because they've infarcted it and it's got a bit of shearing or friction, and they'll start just vomiting up some tin sputum and stuff. I've never seen it, but it's in all the textbooks as something to look out for. Hyper-PE, when we're looking at it, so we classify massive PE as acute PE with obstructive shock, so blood pressure less than 90. Submassive PE is acute PE, and that they've got blood pressure less than 90, but they've also got right heart strain, and they'll have troponin rises as well. And the other ones are low risk, and we just manage them with anticoagulation. This is the massive PE criteria. So this is the ones that we're looking for, and these are the ones that we need to resuscitate aggressively. So systolic blood pressure less than 90 for 15 minutes, dropping blood pressure by 40 for 15 minutes. Then these vasopressor requirements. Cardiac arrest is always a bad sign for most illnesses, if not all illnesses. Bradycardia less than 40, or if they meet clinical criteria for shock. And so this is what we talk about. So this is just a summary of the physiology and stuff. And this is what they call the pulmonary embolism death spiral. So you get a pulmonary embolus, you get this increased pulmonary vascular resistance because it's blocking off that. And from there, you get ballooning of your right ventricle. Okay, this leads to hyperperfusion and ischemia. So we're going to give them some more fluids and stuff. And they're already hypertensive. But the fluids actually increase their right ventricle, and it causes more wall stress, and then they get infective contractility of the heart, and then they start getting the septum between the right ventricle and left ventricle starts to blow into the left ventricle, and they get decreasing left ventricular filling. So they get this cascade where they just keep getting more hypertensive with the more fluids that you actually give them. So the approach to the right ventricular failure in PE, so it's about appropriate fluid resuscitation. You can give them a little bit of fluids, but you're not going to give them a lot. You want to support their systolic blood pressure. You want to decrease their right ventricular afterload, and we want to try to avoid intubating these patients. So this is just a checklist that we can go through, and we'll talk about this over the next few slides. So it's about dealing with the clot, managing their hemodynamics, and managing their oxygenation. So fluid resuscitation. So giving them a fluid bolus will increase their right ventricular preload, but we need to be really cautious because if you give too much, that right ventricle will just dilate further from it, and they'll get really worsening impaired contractility. So the current guidelines and experts talk about, you give them 500 mils. If there's no improvement, they look like they're getting worse, don't give them any more. Okay, they don't need the fluid, all right? Stop thinking that fluids are going to help. You're going to actually make them worse, and you're going to go into this spiral where they're going to get further shocked from it. So we're going to need to support their systolic blood pressure, okay? So we want to avoid hypertension because hypertension is just going to cause more ischemia, and that the right ventricle is not going to have any perfusion to it the more hypertensive they get. So the fluids will generally fail, and we need to just start vasopressors really early in these patients, even if we're suspecting it while we're taking them to the CT scanner. Okay, if you're suspecting it and stuff, start the vasopressors early. Don't try and give them 2-3 litres of fluid while you get them to the scanner to confirm your diagnosis. Just get the pressors on early, okay? And we want to keep the systolic map above 65 to 70, okay? And that'll maintain a good right ventricular systolic pressure. So your agents that you're going to go for and that we can look at first is noradrenaline's generally just going to be your first. So because it is ideal first line in right ventricular failure. And then the second line thing that you can look at adding, so same as sepsis, is adding in vasopressin, because vasopressin is going to work as pulmonary vasodilation. And these patients need that pulmonary vasodilation because they're so congested from the actual clot. Okay. Once you've decreased that right ventricular, or you help supporting that right ventricular systolic pressure through giving your vasopressor type agents and that, you then need to look at ways to actually decrease the afterload. And so the way that we do that is preventing hypoxia and hypercapnia, because both hypoxia and hypercapnia are both potent vasoconstrictors. Okay, so they cause further vasoconstriction to that. So if they're hypoxic, you want to actually give them oxygen to actually get them up. But if they're hypoxic and they're hypercapnic, then we need to decrease their pulmonary vascular resistance. And there's things we can do there, so thrombolysis, or we can do inhaled pulmonary vasodilators as well. So it's about preventing and restricting hypoxia and hypercapnia. So we're going to give them high flow oxygen, so early application for that. Look at the inhaled pulmonary vasodilators, and that's about decreasing the clot burden that these patients are suffering from. So inhaled pulmonary vasodilators actually improve the VQ mismatching, okay, and they actually help with the afterload reduction. So up in ICU, they have drugs like nitric oxide, which is in a big blue bottle that they can use at the bedside, and they use this a lot in cardiac surgery and stuff. It's a bit harder for us to get down here. There's also epoprostenol that they can use up there. We don't stock it down here, and it's a bit hard to get. We've got GTN, okay? And GTN is basically when you give it as a nebulizer, so you give it to them as inhaled, is a potent nitric oxide inhibitor, okay? So it actually helps to pulmonary vasodilate these patients. So it is a short-term stopgap message, and you're using it in the crashing patient, okay? So your dose for giving these patients inhaled GTN, you're going to give them 5 milligrams nebs over 15 minutes. It'll last about 30 minutes, or you can give them 200 to 400 micrograms as a continuous neb. We did this into a lady in T1. She was a cancer patient that had brain metastases. She had a big PE. She was on high flow oxygen at 30 and 30. She wasn't a candidate for thrombolysis. So we gave her 3 lots of GTN nebs to actually try and decrease some of that afterload and help with her pulmonary vasodilation. And after the 3 nebs over about 80 minutes, she was down to about 6 litres of oxygen and about 10 litres of flow on the actual high flow. So it does actually work at the end of the bed. So it's something that we can think about using to actually help with that. It doesn't cause hypertension and stuff like when you're giving GTN, because it's just going through your lungs. They're breathing it in and out, and it's working on your lungs, and that then it goes through to the right side of the heart as such. So it works quite well, and it's a simple thing that you can have in your tricks to actually try and manage these patients. Intubating these patients, they can look shocked, they can be hypertensive, they can be hypoxic. It is fraught with danger. Remembering our induction drugs do cause hemodynamic collapse, even ketamine, which is quite safe, in the sick shock patient will still alter their hemodynamics. So we need to be very mindful with that we can put these patients into cardiac arrest. The other thing these patients won't tolerate very well is the positive pressure from the actual mechanical ventilation on the right ventricle. So we know that that decreases their right ventricular preload. It's going to increase their afterload. It'll worsen their right ventricular failure. And we know that positive pressure worsens your cardiac output in shock states. So ways that we can look at avoiding intubation is we can start them on high flow nasal cannula. We can also pre-oxygenate them first. We want to give thrombolytics first if they're an indicator for thrombolysis. We'll talk about that in a second. You want to try and optimize and maximize your pre-intubation physiology. So you've actually got some room to move. So using your inhaled pulmonary vasodilators for that. In the States and stuff, they talk about, they actually just put these patients on VA ECMO while they're awake. Okay, and it supports their oxygenation and their hemodynamics while they're awake, and then they intubate them once they're actually on ECMO. Because ECMO is going to do the function of the heart and lung there. And so then they'll actually intubate them after that. So they'll put them on it actually awake. And that's something we have access to and can do here through our cardiothoracic surgeons. If you do have to go ahead and intubate these patients, you do need to have an approach. It's best to have your vasopressors running during the intubation, okay, if they need it. So you want to maintain you've got some room to move, so making sure that you've got the systolic up to that 130, 140 mark, then map up to the 65 to 70. You can consider trialing some BiPAP on them first for pre-oxygenation, and this will tell you how well they're going to tolerate that positive pressure ventilation after the intubation. If you put them on BiPAP and their BP plummets and they look worse than that, they're not going to tolerate a tube. It's going to be a clean kill once you intubate them, okay? Have inhaled vasodilators ready. If you haven't got it on, have them ready after you tube them, because you can run them in line through the ventilator circuit to actually help and get them right in there. You want to use hemodynamically neutral drugs, so low dose ketamine, high dose rocuronium. Okay, and remembering your post-intubation sedation as well. You're not going to be able to go too high because they're not going to tolerate it. The first 10 minutes is very crucial afterwards. You want to avoid overbagging because that's going to cause dynamic hyperinflation in the lungs and worsen that right ventricle. You're going to treat them a bit like an asthma, okay? Low tidal volumes, but you want to avoid hypoxia and hypercapnia because they're not going to tolerate it very well. Moving on now to how we actually deal with the clot and that. If they've got a low risk submassive PE, it's just our standard anticoagulation, so heparin infusion and monitoring closely. If they've got a massive PE and signs of shock, we're actually going to go down thrombolysis pathway. And so this is our checklist that's available on the Charlie's ED blogs. It's no different to thrombolizing, stroke, or a STEMI. We didn't have access to a cath lab. There are some criteria that are absolute, so we worry about increased risk of bleeding, and then there's some relative contraindications to having that as well. So this is your screening pathway and stuff. So I encourage you all to have a look at it, all of that. So the principles of giving someone thrombolysis is that thrombolysis is reducing the risk of cardiovascular collapse, okay? So this helps reduce your pulmonary vascular resistance by breaking up some of that clot within that pulmonary tree that's blocking off. So it's about relieving the right ventricular strain and the right ventricular failure. Alteplase is generally safer over giving something like tenecteplase or streptokinase in these patients because there's a reduced risk of intracerebral hemorrhage. And if you give a lower dose, the chance of having an intracerebral bleed with it is about less than 1% from that. Remember, the goal here is that with thrombolysis is it's not going to break up all that clot, okay? But it's about reducing the pulmonary artery pressure to actually improve their perfusion. The body's going to break up the clot by itself over time with long-term anticoagulation. But it's about breaking it up a bit to actually increase that perfusion through the right ventricle. So it's not going to break through all that. And so there is talk now that we should look at giving lower doses because of that. We have a half or a full dose protocol here. So if they're for a full dose protocol, yeah, and they're over 65 kilos, you're going to give them 10 milligrams as an IV bolus of the IV alteplase, and then you're going to run 90 milligrams of it over 2 hours with them. Half dose thrombolysis, where a lot of evidence is currently going towards, and that is where you give them a 10 milligram bolus, and then you give them 40 milligrams over 2 hours. And then there's catheter-directed thrombolysis, where they give about 25 milligrams of alteplase, but they're right at the clot, staring it in the face, where they inject it, and they do that up in interventional radiology. The evidence for thrombolytics, a lot of it is transcribed from the STEMI and stroke literature, although there's more evidence for thrombolytics in STEMI and PEs than there is for actual stroke. Smaller doses are probably better for PE. So remembering like your stroke volume is about 70 mils per minute. So you get a half-life of alteplase is 4 minutes. So it's going to pass through the lungs about 5 times in those 4 minutes, that alteplase. So it's going to have an effect on that clot and start breaking it down a little bit as you give it. It's not going to completely get rid of the clot, but it's going to start breaking it down. You should see improvements in their perfusions. It works better, I think, in PEs because PEs are generally an acute clot that actually is travelled up from the DVT into the lungs. So when we look at STEMI, it's generally plaque build up over time. So it can be a bit more resistive to actually thrombolysis than actual a DVT. And it's about changing our thinking that we don't need complete resolution. We're just trying to break up some of that clot to actually improve their hemodynamics. Just a couple of pearls with regards to anticoagulation. So patients with big PEs, they suffer from pulmonary hypertension post their PE. So they're short of breath, they can look a bit plethoric, poor exercise tolerance and stuff. In the big Moffitt trial that they did, those that actually got thrombolysis actually had decreased episodes of pulmonary hypertension. So had a better quality of life after their pulmonary embolus. Remembering heparin infusion, heparin doesn't actually break down a clot, okay? It prevents more clots from joining the big clot, okay? So it doesn't actually do anything to work on that. That's why we put them on Clexane and your dabigatrins and stuff afterwards and that. Heparin's more about making things, not making things worse. It's not going to actually make things better. Other things that we can try here is catheter-directed thrombolytics. So this is where they're going to give thrombolysis direct to the clot. A lot lower dose. They can do it as an adjunct in surgical thrombectomy, and they can do this up in NISWA, where they go in with a catheter right up to the clot and they try and thrombolyze it at the site. Surgical embolectomy, and I'll show you a little video of a surgical embolectomy in a minute. It does have a bit of a risk. Procedural mortalities about 10%, but they'll do this in patients that are contraindicated to TPA. So if they've got bleeding in that, well, they've got a massive PE and they have failed thrombolytics, they're not getting better with pulmonary vasodilators. They're getting more shocked. They'll actually cardiothoracics will take them and they'll try and do an embolectomy. And you can see that they've incised the pulmonary artery and they're going in with a catheter to try and suck out the clot from there. ECMO we can use as a bridge to surgery or a bridge to getting thrombolysis to work. Remember, you're going to want them on ECMO before you thrombolyze them, because once you're trying to put those big catheters into the groin with thrombolysis on board, it's not going to end very well. Okay, but these patients are often excellent candidates for it. You use it to stabilize them before intubation, or if they've got instability despite thrombolysis, then you need to weigh up the risk versus benefits of trying to put these cannulas in. So we get Ben off to operating theatre after we thrombolyze him. He's still not improving. And this is just a case that shows what they would do to actually surgical embolectomy. So that's what a big clot looks like. Okay. Just finishing off, if you've got a patient that's in the department that you know has got a big PE that goes into cardiac arrest, this is an algorithm or an approach that some of the experts recommend. So you give them a 50 milligram IV alteplase bolus if they haven't already been thrombolyzed. you're going to give them adrenaline bolus, then you're better off running them on an infusion of adrenaline so that they get continuous hemodynamic support. You want to really limit your airway pressures. You can start pumping in your inhaled pulmonary vasodilators by your ET tube. Consider putting these patients onto ECMO. But the thing is, once you thrombolyse them, you've got to give time for that thrombolysis to actually work. And when they're in cardiac arrest, the circulation's even poor. So you've got to actually work on them from at least 60 minutes of good CPR to actually get that thrombolysis around the system to actually make sure that it's working and stuff. So it's just an approach to leave you with. So I think the take-home point, if you come across to a union resus and you're looking after someone with a massive PE, you want to start vasopressors early on these patients. Be conservative with these fluids because you're going to make them worse. Consider trying inhaled pulmonary vasodilators. It's going to make them better rather than worse. And if they're shocked in that, then we should consider and advocate for actually thrombolysis for these patients. They do better with it. Okay. I'll stop sharing and I'll take any questions.
Do we ECMO? Okay. Does that start? Are we doing it? I thought we weren't doing it.